Hello friends. Today we'll be talking about MIGS for pediatric glaucoma. I'm Sushmita Kaushik from PGI Chandigarh, India. Informed consent was obtained from the parents of all children to allow the use of photographs for academic purposes. We know that children are a different challenge altogether. We have to manage not just their pressure, we need to look at their vision, indeed a whole lifetime. And trabeculectomy will always be a ticking bomb, and tubes are even bigger bombs. The idea of ab-interno surgery, therefore, is to spare the conjunctiva. There's minimal disruption of the conjunctiva, sclera, and iris. It bypasses the abnormal trabecular meshwork, but remember, it does not preclude further surgery. So before you enter the arena of MIGS, ask yourself, why enter? Why learn? Trabeculectomy is tried and tested and efficacious, but you know that there's a risk and complication associated, and that's why you're entering it for adequate IOP control minus the risks. The pathological angle in developmental glaucoma was described very well by Sampaolisi nearly a century ago because the angle doesn't recede normally. So this is what a normal infantile angle looks like. A type 1 angle has a TM which is visible and it's amenable to angle surgery, whereas a type 2 angle has a severe goniodysgenesis which is likely to require a combined surgery. So the gonioscopy before attempting to do a MIGS will give you an answer as to how likely your procedure is going to succeed. Now, once you've made up your mind, you can do it. Read, watch videos, and if possible, assist. Get the opportunity to assist people who are doing it regularly. Most importantly, I would say invest in a hands-on dry lab or wet lab. Nothing works more than getting a feel of the procedure yourself. And we're very fortunate that in PGI we had Dr. Leon and Sunita over for this wonderful workshop which attracted a countrywide audience. So the first steps are, of course, get the equipment, get your direct gonio lens, whether it's Swan Jacob, whether it's one of the disposable lenses, and have a microscope with a tiltable head. So why do you need that? Understand the funda. This is the angle which is usually not visible. If you tilt the head and you tilt the microscope, you'll have the light going straight into your eye. So here is a small baby just before surgery. We are trying to look at the angle, and you can see that's the Swan Jacob lens which is just resting on the cornea. Don't press too deep, and you can then see the angle if it's adequately tilted. Well, it's time to start. We are fortunate that we have Dr. Leon's dry eye models, but it can work on any of the model eyes available in the market. Getting the feel of holding the gonio lens and tilting the microscope is the first step. And here is one of our second-year residents who's attempting her MIGS on a model eye, and it doesn't seem as easy as it is when you're assisting. So she's in a bit of a trouble, and you can see here she's picking up her gonio lens, but I can see that the microscope isn't tilted enough. And so that struggle continues until a helpful senior resident comes across and says, oh, you can't see it because you haven't tilted the microscope enough. And then he obligingly comes and tilts the microscope for her, and then finally the angle is visible. The next thing to do is train to see an en-face view of the trabecular meshwork. So now she's seeing the angle because it's been tilted enough, but this angle is not good to do goniosurgery in. So you need to have an en-face view, so you have to tilt the head a little more, and there you are. The trabecular meshwork is now en face, which means the whole surface is in front of you for you to do your angle surgery. Now comes the real thing, surgery on the angle. So you can see she's put in her MVR blade and she's at the trabecular meshwork, and let's see what it looks like. So she's put this in, she's learned how to get the en face view. That's a good en face view, that's there. And then she puts in her MVR blade, and there you are. The next thing you know is she's ready to do her trabeculotomy or a goniotomy. And there it is, and all you need to do is incise it. So let's dive into the real world of childhood glaucoma. So here is the same thing that we've done, an en face view, and the tip of an MVR blade is engaged, and incised, and you can see as it's being incised, that's the cleft formed. This is the cut end where you can see that white border of the Schlemms, and that's the uncut end which is being cut now. In a snapshot, this is what a dysgenetic angle would look like before surgery, and there is the tip of the MVR blade, and once we've gone through the huge cleft that's formed, which hopefully would bypass the dysgenetic meshwork and allow filtration out. So it's been an encouraging journey so far. We've published our results about 2 years ago in the IJO. With one goniotomy for these infantile glaucomas, we had success in 76% of our children. But when we combined it and did it in the temporal region after the nasal, we really had a 90% success. So the goniotomy really stood us in good stead. So the next thing is bang. Now, bent angle needle goniectomy is something else, where a trabecular meshwork is excised rather than incised. So the principle is to use a 25 gauge needle which you bend at the tip like a reverse cystotome, and there it goes in at the trabecular meshwork. And the beauty of this is that you can actually see a bit of trabecular meshwork at the tip of it, which you'll see in a minute. So we've used it in children. It clears very well, lasts well for about 3 to 4 years now. The question in our mind is, do you need it? Is bang really better than a goniotomy? And the best way to do that was a small parallel RCT. We just published it this month in ophthalmology, and we took eyes which were very similar in primary angle closure, in primary congenital glaucoma patients, and that was the challenge, because we randomized one eye to bang and one to goniotomy, and we did it simultaneously. And at the end of a year, it really didn't matter. What you didn't matter, it was the same. So now we don't think a bang and the additional expertise required with it is generally required for these small babies. So at least in PCG, we can say that a goniotomy is good enough. But what has really helped us is 360 degrees gonioscopy assisted transluminal trabeculectomy, or GAT. So remember, we said that when we combined a temporal with a nasal goniotomy, the success was almost 90%, which obviously told us that more angle is better IOP and better control of the glaucoma. And therefore, when we started doing the GAT for primary congenital glaucoma, that has really helped. So the idea is do a small goniotomy, take a 5-0 Prolene, which is blunted at the tip with cautery, and then pass it right around. Sometimes it slips, and there you catch it again. And then you hold the other end, and voila, you've stripped out 360 degrees of the trabeculectomy just like that. No extra equipment is required, and as we said, the 5-0 Prolene is good. So how does it fit in? This baby had glaucoma since birth, underwent a bilateral trab with trab, Peters in the left, bad PCG in the right. It worked, but it didn't work enough. So we thought, rather than going in with a second surgery or a second trab, let's try a goniotomy first. And we did. So when we tried a goniotomy, and we call this a secondary goniotomy after the first one, you can see it's a little hazy, but you can still see a bit of the trabecular meshwork there. And to our surprise, it really worked. So sometimes you can do it as a second sitting, as a second surgery before opening up the eye again, and it works. We do GAT when we want a little more than a goniotomy, but we don't want to do a trab with trab. So this baby with obviously asymmetric PCG, obviously worse eye, we did a GAT in the right and a goniotomy in the left, and it worked. There are some sad stories. So this is a patient who we did a combined trab with trab, came back 5 years later, post-COVID, with panophthalmitis, and everything was just flowing out. We couldn't save this eye, but the left eye had high pressures, and we were really scared. So we thought, okay, let's do a GAT and treat the remaining angle, because at that time we didn't do angle surgery. So let's treat the remaining angle, and interestingly, in a bit, you'll see that the suture actually came out from the previous trabeculectomy. So actually, even that was open. So we just held it, and we went right around, and once we wrapped around it, it worked. So sometimes even this comes to your rescue. This is recent, and we'll just wind up with the last case, this 4-month-old girl with acute hydrops, distraught mother. that she was fine, and 2 days ago this cornea has gone white. 26 pressures in the left eye, and put her on Dorzox and scheduled surgery. So we scheduled it 3 days later, and surprisingly, it had cleared quite a bit, and the pressure had come down. So we said, all right, let's take a chance and try. But the gonioscopy was so hazy, you could hardly see the angle. I wouldn't have known where to make the incision and what to do. But when we still went ahead and thought we'd try, so here's the gonio lens. You can see that it's very, very hazy. But when we manipulated and moved the gonio lens, we realized that the superior nasal angle can be visualized actually. So I took that chance and we went in, and we made the goniotomy, and then we did the GAT as usual. And surprisingly, we managed to work, and it did work. So we are very happy with the GAT as yet, because as long as you can see the angle, it seems to work. So you can see there goes the MVR blade. This is making the port for the 5-O-proline. So that's the blunted 5-O-proline that is going in. And once it's in, then you put in your gonioscope. And now the tricky part is, where do you make the goniotomy and where do you open up the Schlemm's canal? So we went a little inferior than usual, and you can see how much the light is being scattered by that corneal edema. So it was a little disturbing. But anyway, we made the goniotomy, we pulled it down, and when we grasped it, it actually slid in quite easily. And so we hope that it'll come out through the other end, and we waited with bated breath as we kept putting it in, and voila, it didn't take any time at all, and here it is. And that was real time and really quick, so it actually takes hardly any time, and it's taken away the trouble from a combined otherwise. 2 weeks later, she's fine. The cornea has completely cleared, and this is really 2 weeks later. The pressures have come down, and the axial length has also reversed. So far, so good. Fingers crossed. But if it does work, we'll be very, very happy. To summarize, MIGS in children is something to do, even if it's hazy. You can do a goniotomy, you can do a GAT when you want a little more. They're expanding to include more trabecular meshwork and excise rather than incise. But remember, they're viable, they're safe, they're low-cost procedures and worthwhile a first procedure. I thank all my residents and the babies who've given us so much of joy, and without which this work would be next to impossible.